Good afternoon. This is Dr. John Bennett broadcasting from Miami Beach, Neurosurgical TV. Today we have the pleasure of having Herman Leonardo Abril Arenas, a neurosurgical resident from Tyumen, Russia. Ibrahim Salamov arranged this. He's going to talk about neuronavigation and vertebral neurosurgery. First, let's meet the panelists to introduce them. Good day, Marco.
Good day to John and all the panelists. Nice to meet you. My name is Marco. I'm from North Italy. I'm a consultant neurosurgeon.
And a frequent visitor here. Ibrahim, please introduce yourself.
Hello, everybody. My name is Ibrahim Salamov. I'm a resident first year in Federal Center of Neurosurgery in Tyumen. It's a city of Russia.
Yeah, he's a very internet smart blogger too. Okay, Yonghong Wang, could you please introduce yourself? Are you there now? You may have stepped away.
Yeah, yes.
Go ahead.
Yes.
Go ahead.
Oh, good.
Could you please introduce yourself?
I'm from China and Shanxi province neurosurgery doctor. So very glad to see all of you and have a discussion, some problem. Okay.
Very good. And a gentleman,
Okay.
I know him from the internet. It's the first time we come here. Hello, Reza. You're muted there. Let me unmute you. Okay, go ahead.
Hello. Hello.
Yeah, go ahead. Introduce yourself, please.
Oh, hello. I am Reza Sabiri from Afghanistan. I'm a member of European Association of Neurosurgical Society, and I'm working in London. I'm very happy to stand here today.
Okay, it's good to see you.
It's a pleasure for me.
Yeah, it's good to see you finally. I've seen you a lot on the internet. Okay, Leonardo. Okay, Leonardo, it's all yours. Introduce yourself and go with your presentation, please.
Okay, best greetings for everybody. I'm Herman Abril from Colombia, residence first year in the section of university. Right now I'm doing my practices here in the Federal Center of Neurosurgery from Tyumen. Is a very expensive pleasure for me to enjoy and share a good moment with you. Today we will go to speak about neuronavigation and vertebral neurosurgery. Well, everyone knows that right now is completely oftenly necessary use the neuronavigator and the help of the technology to reduce the risk of bad medical practice. And this is the reason why we introduced the help of the neuronavigation in the vertebral service here in our center. First time it's necessary to remember some landmarks of the anatomy or the structure of the segment of the spine. Remember that every one of these segments, it contains different details, anatomic details. Like the same in the cervical area, there are anterior and posterior tubercle. The bodies are really small and the lamina is a long lamina, and oftenly the canal or the foramen is very large. And second time, remember, in the thoracic area, the thoracic segment is not the same anatomy because oftenly the pedicular area are covered by the immediately superior or immediately superior lamina. And finally, in the lumbar area, the pedicle area is the strongest pedicle from all the vertebral area. Why I speak about I speaking about the pedicular area because this area where we will go to fix the screw when we use the fixation, but the same during fractures or listhesis or other kind of disease. This is other way to understand the special landmarks of anatomy of every one of the segments. But the same here in this picture, you can see the big area, the big pedicular area here. But if you see in this other picture, the pedicular area are completely small, completely teeny. And remember always here, this is a very beautiful picture because we can understand this is the red area is the pedicle, and the green big area is the lamina. From a posterior view, we can understand that we can see the pedicular area are completely covered by the lamina. This is the reason why we didn't know if the laminectomy will be performed in this area, or in this other area. But the same in this schematic picture, we can see the small area, the small pedicular area covered by the processus spinosus and the lamina. This is the last part of the cervical segment. Why is important use the neuronavigation in the vertebral surgery? Because if we don't use it, we have some difficulties, like the same dynamic changes, the respiratory movements, the change of position, change of physical frame, etc. Poor quality of previous diagnosis images. Sometimes it's not enough with the MRI. Sometimes we have CT and other kind of things, and the quality are completely poor because was realized in a different center. And the heterogeneity of the degree of medical training. We now, young surgeons often perform some mistakes, and all the surgery with a very high degree of training performed the surgeries. But with the help of the technology, we can relieve the rate of mistakes. Advantage of using neuronavigation system, it helps prevent the soft tissues because we can do it at controlled and smaller dissections, improve the probability of correct screw insertion, reduce the risk of fracture, is a very frequently complications, reduce the risk of large vessel drilling, is a no commonly, no oftenly, but is a very dangerous complication. The reduce of the risk of the space conflict between the screw points. The post-surgical recovery is a little fewer, and a long-term complication like chronic pain are completely started, so that is relieved. All these things so that we can calculate the trajectory of the screw, but the same too in osteoporosis and osteopenia. But it's easy to speak about mistakes, but easiest see the mistakes. But the same in this picture, we can see that the screw are invading the spinal canal. In this area, we can see how we can make like a dissection, parts of dissection of this root, this listhesis, but the same, we can fix it, but if the screws are not located in the correct place, it's impossible to arrive to this ideal place. In this beautiful picture, we can see the completely fracture of the vertebral body and inning the completely lateral malposition or wrong position of the screw. Here, but the same, we can see how the screw are affecting the vertebral canal and the pedicular area, and hyperostosis after some years of a wrong operation. This is only some examples of these kind of mistakes, a completely catastrophic situation for the patient. How can we use the neuronavigation? There are a lot of brands, a lot of designs, but here in our center we use a device like this, developed by the Medtronic laboratory. This is two infrared cameras, and this is the screen. Then how it work? We use a pointer and a special antenna and a pointer or locator. Then on first time we performed it, we done intraoperative tomography, and after that we introduce our images in this system, and with the help of the antenna and the pointer we can calculate and project the trajectory of our screws and get the best position. Some years ago, we used monoaxial screws. Thanks God, right now we have polyaxial screws. is better, are completely better, because we can change the direction, the location, and the position of the head, and thanks to this special characteristics, we get best results. And after that, we use a combination of a lot of instrumental. This is by the same other Viper system to help to complete the fixation. And using this kind of help, this kind of technology, we can get this kind of results. If you can see, this is the ideal or the best position, location, and orientation of the screws, and at the same in a post-operative, I'm sorry, not intraoperative images, we can see and control if our screws are located in the correct place or not. 1, 2, 3, 4 screws. This is a three-dimensional reconstruction, and this is a lateral view, and this is other view. Down the help of special software, we can calculate the trajectory of the screw. If you see in this picture, the blue area is the area covered by our pointer, and the yellow area is the area covered by our future screw. Then we can look, change, and try to find the best place to insert our screw. Here you can see a lot of options. We can change the diameter, we can change the length, we can change the condition and characteristics of our screw, and in we can save the position of the other screws that we did put it in the patient by the exam. And after that, we can use a special pointer, and only when a simple click over every one of these points, we can remember where was located all the other screws. This is other picture, different picture. You can see the small size of this screw and the completely different location, position, and projection. Why? Because we are working in the cervical area. This is thoracic area, and this is a cervical area, are completely different. This is the reason why I began speaking about the landmarks of anatomy. Oftenly, we locate our antenna over the C7 or over the iliac crest, because it's a very safe place. And after that, we use our pointer. Of course, we on first time done the dissection, and after that, we are looking carefully the best position to do the dissectomy, the laminectomy, and after that, we introduce every one of these screws. This is the final result of our surgery after the fixation, and I want to speak to told you about special characteristic of this technology help, because by the same in this picture you can see where are located the highest density of the bone. But the same, this is the cortex, and these two small areas are areas with osteopenia or areas with osteoporosis. Then we suggest you use the cortex like a point of fixation of the screw, not only the pedicular area. We try to locate the screw like you can see in this picture, because you use the pedicular area and the cortical area to fix in the best place possible the screw. Here I will show you a short video about the recognition of the pointer. After that, we are looking for the best area with the help of the screw and the system. You can see in the real time how is projected the screw and how is projected the trajectory in the patient. And after that, we choose Well, what will be our place and fix it? This is is a good moment. And finally, we will mark the point. And these are the small button, and we can click and save, like you see in this area, the new point. Tim, if you have the technology, if you have the training, if you have the possibility, I invite you to use it, because really down our environment, we can see so that thanks to this technology, our rate complications are so poor, near to 3 or 4% by every year of patients present problems related with the introducing of the putting the screws, and the oftenly mistake rate is now so far from 2 or 3 millimeters. Then is a very good situation, is a very good help. Thank you very much by your attention, the best wishes for you and your surgical practice.
Okay, very good. Thank you very much for your time and excellent presentation. So how's residency going, Leonardo?
I'm sorry, again, please.
How is it going in residency? How are you doing in residency?
Well, this is my first year of residence. Of course, I'm beginning, but well, thank you to invite me and let me introduce me in this new world for me, the amazing world of neurosurgery.
Very good. I've been to Colombia and ate some mazote in Bogota.
Yes, it's our capital town, but I'm from Bucaramanga, from Santander.
Oh, okay, yeah, different from Bogota. Okay, we'll open it up for comments and questions from the panelists. Any comments or questions from Young Hong, Ibrahim, Reza, or Marco? Go ahead, Marco.
First of all, I want to congratulate with Leonardo for your wonderful presentation, very, very beautiful, very complete. I just want to add one thing, even from my personal experience in spinal surgery. Another problem you can face when you perform spinal surgery without using the neuronavigation is in patients with scoliosis, because you find in scoliosis you have not only a curved spine, but also a rotation of the vertebra respect the other one. So put the screw in a vertebra that is rotated respect the other, you can have a wrong trajectory if you don't use a neuronavigation.
Yes. The chronic pain is a very common complication because, like you see, the malrotation after performing the surgery and inning. This is very high risk when you use monoaxial screws. This is the reason why we recommend to use polyaxial screws to relieve the rate of this kind of complication. Yes, it's completely true. Thank you for your report.
Thank you very much.
Thank you. Okay, any more comments, questions? Young Hong, Reza? Any comments, Reza? Let me unmute you there. Are you there, Reza, or no?
Hello,
Reza?
I'm here.
Yeah, okay. Do you have any comments or questions for Leonardo?
Well, dear Leonardo, thank you so much for your great presentation, and I want to say many congratulations to you. Well, I haven't a question about this presentation, but can you tell me something about neurosurgical residency in Russia?
Yes, of course. Mainly there are two ways, the Russian ways and the foreign way. Oftenly the Russian residents, he done 2 years of residence, and after that there are a second modality called aspirantura. It's like a special work oriented, a little more oriented by the researching and administrative things, but of course including practical training. And for us, for foreign students, we done a similar program like in our country, but the same. I'm from Colombia. In Colombia, the residence training, it has a duration no less than 5 years. This is the reason why here in Russia I will do to 5 years. But of course, here in Russia, it's completely necessary the Russian language to perform this kind of residence, this kind of training. The English language always helps, but better in Russian language. But the same here in our center, Federal Center of Neurosurgery, here in Tumen, we perform it every day, no less than 25, 28 operations every day. And the summatory of all these operations is more or less 3,000 operations every year. This is the reason why it's a very good place to practice, because there are a lot of operations. Is a very good opportunity. Including too, we have a very high level of technology, like the European.
How long did you know any Russian before you went there, Leonardo? Did you know Russian before you went
level
to?
or the Japanese level or no. Only what was the reference? I started in Cuba. When I was in Cuba, I had a lot of professors that get their information here in Russia, and they always say me, here in Russia, there are a very good level of academic things. This is the reason why I choose this place to become a neurosurgeon.
Did you know Dr. Sufianov? Do you know of him before you went?
Yes, of course.
Okay.
The Dr. Sufianov is our chief professor. Always is a completely pleasure to work together with him, because it's
and perhaps Abraham can tell us. You know, it's a research center in Tyumen, correct? It's one of the research centers for Russia.
We have not neurotrauma in our Federal Center of Neurosurgery. We have not neurotrauma.
Okay.
It is maybe 1 minus this.
Yes, oftenly in our center we perform elective procedures. We don't get emergencies or don't get trauma. But through our university, section of university, we can get a special rotation, special course about trauma in a different place. And this is like a spam, but every year here in our center, we organized around 18 or 19 congress or symposium. Then we invite you to participate here, because from people from Brazil, from Spain, from Mexico, from America, from Australia, from Thailand, from India too, and it's a very good place to do it.
It's a real mix, huh? It's a real mix. Wow. For people from all over the world there, huh?
Yes, and always it's amazing to see different schools, different techniques, different professionals, different doctors performing operations, because you learn different ways to do the same thing.
Okay, very good.
And I want to say thank you, Dr. Bennett. Thank you, Herman, because this first step of our to international conversation to surgical TV. And thank you, Dr. Bandit.
Yeah, well, we hope to go further, especially in a country like Russia, where it's so big and spread out. I'm sure there are a lot of neurosurgeons that don't have access to, to conferences and also to late, technology that's developing and changing in neurosurgery. And I feel, Abraham, that this platform will improve education, especially in rural places. You're going to see, as a neurosurgeon, you just handle everything in the rural areas, tumors, trauma, everything, pediatric. So I think this platform will help with education and will certainly help you guys grow. And I'm sure you're going to grow, being internet smart, Abraham. You know the power of the internet and how to bring people together. Let's introduce a couple of people that just came. Batura, could you please introduce yourself to the panel? Just unmute yourself, because one of the beauties is networking. Go ahead, Batur. Please introduce yourself. Whoop.
Hello, my name is Batur. I'm graduated neurosurgery education in Russia, and I have been in few times in Central Neurosurgery in Tumen. It's a very good opportunities in center and research. I know with Professor Sofianov, and so many times we are meet, and I learned, I see, and how he is operating.
Okay, you're in Tayuman also. You're also in Tayuman.
Yes. No. I'm in now is Mongolia.
Oh, great.
Yeah.
Great. Welcome.
Yeah, I'm a postgraduate student in Russia. Ufa.
Okay. Very good.
Of Ufa.
Very good. Welcome.
Yeah.
Welcome. Okay.
Yeah.
We're just
now I'm working in military hospital of Central Military Hospital, Mongolia, and surgery department.
Wow, you're the first person I ever met from Mongolia.
Yeah.
That's great. That's great. And Raza, I see you're in London now.
Yes, of course.
Great. And you were in Turkey before, right?
After I attending in the World Federation of Neurosurgical Society, I stay at Turkey for 6 months, and after that I traveled to Afghanistan. As you know, we need good education in Afghanistan. I go there and help to our brain surgeons and spinal surgeon for 2 months, and after that I back again in London. I have a planning for Christmas, maybe 2 weeks. I back to Afghanistan and help to our brain surgeons for treatment.
Very good. Okay, welcome to everyone. This is an excellent start, Abraham, to your channel of Young Neurosurgeons, the Society of Young Neurosurgeons of Russia, and we welcome further presentations. And thank you very much for taking the time to get that together, Leonardo. Y también tú estás bienvenido a nuestra comunidad de español, también.
Hombre, gracias. Muy amable, de verdad que es un placer.
Sí, tenemos un canal en español también. I'm just saying we have a channel in Spanish also. And we'll
Soy un fiel seguidor del canal en español también, muchos colegas de México, de Argentina, por allí participando.
Sí. Abraham, it's all, I started the Spanish channel in Spanish because some neurosurgeons like their language. And I have a feeling in Russia it's the same. There are some neurosurgeons that prefer Russian. And we're very willing to do presentations, Batur, in Russian if you guys want to. So that's no problem. Don't let that worry you. Okay. I'm gonna stop recording, and you can stay here. And thank you. A great first presentation.